Hello, I'm Dr. Bolanle, your host on the BrightMindsMD and your mental health podcast. Here, we discuss topics designed to explore the full spectrum of mental well-being. You'll hear from experts and listen to personal experiences that inspire and inform. So, whether you're seeking insights, solutions, or just a dose of motivation, this podcast is your perfect companion. Hit that subscribe button and join us on this incredible journey to mental well-being. Your whole health starts with your whole mind. Let's get started.
Hello, everyone. Whoever's listening and joining us, my name is Dr. Akinronbi. I'm psychiatrist and founder at BrightMindsMD, a psychiatric practice service in New Jersey and New York, helping people with depression and anxiety feel better and live better using fewer medications and wellness practices. I'm excited again today to have one of my colleagues with me, joining me for another helpful topic relating to our mental wellness and health. I have Dr. Carlene MacMillan. I'm going to let Dr. MacMillan introduce herself, and thank you for joining us, Dr. MacMillan.
All right. Well, awesome. Thank you for having me. So yes, my name is Dr. Carlene MacMillan. I have a board certified adult and child psychiatrist and practice in Brooklyn, New York. I have a practice called Fermata, which specializes in something we refer to as interventional psychiatry, which means instead of just prescribing medications and therapy, we predominantly do procedures like transcranial magnetic stimulation, otherwise known as TMS, which I think we'll be talking about today. And then the other hat I wear is I'm the Chief Medical Officer for Osmind, which is an electronic health record platform for psychiatrists and others doing breakthrough mental health treatments.
Awesome. Thank you for joining us, Dr. MacMillan. So let's get right into it. TMS. What is it? I mean, I do know what it is as a psychiatrist, but again, for everyone listening, I feel like not everyone has had the introduction to TMS and know exactly what it is and are curious. What would you tell them about TMS and what it is?
Yeah, so most people have heard of ECT, or sometimes colloquially known as shock therapy. It's been around for decades, kind of gets a bad rap sometimes in movies like One Flew Over the Cuckoo's Nest. The reality is that treatment, which uses electricity, is very powerful for difficult to treat depression and some other conditions. But that treatment often requires being in the hospital, and it can have pretty significant impacts on memory and cognition. So the field, we really wanted to develop alternatives to that were equally powerful, but didn't have some of that side effect burden and could be done in the outpatient setting. So that's where TMS comes in. TMS has actually been around for the FDA-cleared it in 2009. So we're talking about 15 years. And it's a procedure that uses, instead of electricity, it uses magnets to cause neurons in the brain to fire. And the saying in neuroscience is neurons that fire together wire together. So TMS is FDA cleared for depression, OCD, and actually smoking cessation, depending on the protocol and device used. And what it means for patients is they come into typically an outpatient office. They get a procedure, usually about 20 to 30 minutes, where they either wear a helmet that has a magnet in it, or there's a little thing called a figure 8 paddle that has magnets in it. You get that. It feels like a little bit of a very aggressive woodpecker knocking on your head. Makes sounds kind of like what an MRI sounds like if you ever had one of those, because that also uses magnetic energy. And then you go on with your day. And then you do that over the course of time. So you get typically 36 to 50 sessions of those, either once a day, which is the traditional insurance-based protocol, or there's an accelerated protocol where you can get up to 10 a day in a shorter period of time. And so this is a treatment that we offer. Many places around the world offer at least the daily one, and more of us are doing these accelerated ones so that people can get better faster.
Awesome. Thank you. That sounds very intriguing, actually. You mentioned accelerated treatments, and you said, did you say 10 a day, or you mean a 10 session treatment? I wanted you to clarify
10 a day.
That a little bit.
Yes.
Okay.
So TMS, traditional TMS started in, since 2009. A couple years later, commercial and government payers like Medicare and Medicaid develop coverage policies to cover it. The version that's covered by insurance consists of one single session per day, so that 20 to 30 minute session for 36 days. So in reality, that amounts to about 2 to 3 months, depending on how often people are able to come in with their schedules. You can imagine it's, depending on if you live near an office or not, it can be challenging, and people are sometimes working and in school, so it can be challenging. So in the past, I would say 5-7 years or so, many of us in the field recognize, well, wait a minute, maybe we could do more than one per day and space them out. Sort of like you don't just study one flashcard, or you don't just do one sit-up, right? You do like repetition, and that there's something for that repetition that seems to teach either brain or the muscles in your abs, right, to learn and change. And so accelerated TMS protocols really mean you're going to do the same number, or sometimes a little more even, over a shorter period of time. So the protocol that was approved by the FDA in 2022, known as SAINT, also involves an fMRI, but the key thing really is that it's 10 treatments per day for 5 days. And that came out of Stanford. The work on that is showing suicidal ideation and depression going into remission, suicidal ideation disappearing, for around 80% plus of people, which is the same type of response rates we get with ECT and far better than the response rates we get with oral antidepressants.
Wow.
So accelerated protocols, I think, are where it's at. Doing a lot of advocacy at the national level to try to get insurance coverage for them, because right now, in order to get them, unless it's part of a clinical trial, which again has tons of qualifications, a lot of times it's only available to those who can afford it. So we're really working to get that parity with traditional TMS.
Wow, Dr. MacMillan, that is exciting. Being able to complete treatment in pretty much one week, 5 days.
5 days.
Week.
Yep.
And get remission similar to ECT without needing like anesthesia, without needing, the long pre and post that happens with ECT or long treatments with medications. That is super, super exciting breakthrough. And I'm thinking, well, if, with these kinds of results, and if we continue to get results like that, why would we be thinking, or are there thoughts about starting everybody with depression just at that level and getting them better? Or who would be ideal to refer for treatments like that?
Yes, I'm glad you asked that. So in the original TMS trials, back in the late 2000s, they really just said that you needed one prior medication trial in order to qualify for the trial. So the makers, the original manufacturers, they really intended this to not be a third, fourth line treatment. Maybe not first line, right? Like try medication first, because this is kind of a big commitment, but to really do it earlier in the course of care. Now, treatment-resistant depression, there's no real formal definition. Most of the life sciences industry will describe it as 2 prior failed medication trials. So we've seen insurance companies, initially, many of them, and some still do, have a requirement of 4 prior failed antidepressant trials. The reason they did that, because it turned out in the original trial, even though they only had to have had 1 failed trial, the average was 4. So they were just like, oh, okay, let's make it 4. That was never the intention. The intention is absolutely to have this earlier in treatment. So what I generally offer to someone that has had 0 med trials, no, unless, they're really adamantly opposed to oral medications, or, many of these medications, the safety profiles are still reasonable in pregnancy, but, sometimes people don't want that. This is very safe in pregnancy. So we are all wanting it to be done earlier. And I think, I applaud the insurance companies, which is, don't always applaud the insurance companies, but I do applaud them for listening to us. We're at the Clinical TMS Society, we advocate very strongly and provide them with evidence that they should say, only 2 medication trials. There's a handful that are only 1. And absolutely, that's what we would like to see, because we know from the STAR-D trial and other trials that we used to say about 2/3 of people would respond to oral antidepressants, and there's been a recent reanalysis of that data that actually flips that a bit and suggests that maybe only 1/3 respond, and which is not great. And then there's just like diminishing returns after that. So maybe you try one, it doesn't work. Maybe you try two, a different class, and maybe it works, but it's like really diminishing returns. So the types of patients that come to see us at our practice, Fermata, I've literally seen people have had 26 failed med trials. Like, is the 27th going to work?
Right.
You know, really no, unless it's a totally different mechanism of action, which we do have some medications. We have one on the market now, only two on the market, and some in the pipeline that do have totally different mechanisms of actions than acting on serotonin or epinephrine, and that's exciting too. But the idea that like the 6th SSRI is going to work, no,
it's not the same thing.
No, and it's very demoralizing. People just try things over and over. They lose trust in the system. They lose trust they can feel better. And the people that were in these accelerated trials, in the Saints trial out of Stanford, these were the most refractory. Some of these people had failed ECT trials. I mean, these are very unwell people that were getting better with TMS, which is just like, they're not cherry picking for, oh, I bet this person's likely to respond. Like, no. We're talking about really severe refractory depression responding.
That is exciting news, and I'm surprised we're not. I mean, I've heard about, I've looked into the Stanford protocols, or I've heard it talked about, but I think that if this is the next wave in psychiatry, we should all be talking about it a lot more. And what relief it would be for our patients to have hope that, they're not going to try 26 medications and get nothing, or even wait to get 26 to get something. Or just the idea that we don't know if this is going to work for you, if something's going to remit, if this is powerful and way more convenient than ECT. And also,
Yes.
You mentioned pregnant people, not wanting to introduce medications into the system. This is a excellent alternative. I'm really, really excited about what that means for the future of depression treatments. I know that FDA has approved TMS in general for also OCD and smoking. Is the accelerated protocol, right? So that's the traditional TMS, of course. Is it accelerated protocol being applied to those indications as well?
Yes. So, yes, in sort of off-label manners. So the OCD protocol is actually using a deep TMS helmet, because we know that the brain structures involved in OCD are a bit deeper in the brain than in depression. So the helmet is able to get to that deeper area. And the protocol that was approved by the FDA is 29 sessions. Why it's not 30, I don't know. I think they're just sort of messing with people that want nice numbers, which is ironic. But we oftentimes just do 36 because the insurance approves 36, and I don't think there's anything magical about 29. But the interesting thing about the OCD protocol, I really love it because we get to work in conjunction with our psychologist colleagues and other people that are doing OCD therapy, so exposure response therapy. So it's not a passive treatment. When you come in to get the OCD TMS, you actually should be doing the exposure work. We call them provocations. So if you have a contamination concern, it's putting the person on the floor in the TMS office. If it's more of a mental compulsion, it's oftentimes for our patients, I'm wondering if this is going to work. Is this going to cause brain damage? What if this doesn't work? Maybe this tech isn't very good. Like, all of those doubts and not getting reinsurance is actually like activating that OCD circuit. And we love to work with our psychologist colleagues to come up with those interventions. And over the course of somebody getting OCD TMS, what was provoking to them and causing anxiety on day 1, on day 20 is no longer. So they're working through their hierarchy of anxiety OCD triggers. So that's really cool. There are several of us that do, kind of clinical my AirPod. Hold on a second. Love the AirPods. They don't always stay in my ear.
Right.
So they're doing accelerated protocols where we are actually trying to do these in an accelerated way, similar to the same thing, doing 10 a day, 5 a day, Not everyone is right for that. We actually just got a paper, poster accepted for the Clinical TMS Society annual meeting coming up in June in London on this very topic about accelerating OCD treatment. For some patients, it's too hard. I think mechanistically it makes sense that it works, but for some patients, it's really hard to imagine if you can spend multiple hours per day sort of in your OCD. That can be too much for some, but it really just depends on the person. And we have seen some good results for folks where they're able to tolerate doing that.
Interesting.
Yeah.
And in terms of doing these accelerated protocols, are there breaks in between the sessions, or are they all done as sessions one after the other?
There are breaks. Yeah. So I really do think of it like when you go to the gym and you do like sets, and you do then you kind of do your circuit. You do the sit-ups, and then you do a little bit on the treadmill, and then you do different things, and then you like rinse repeat, right? But you're not doing them all over and over. So with the accelerated protocols, the study so far suggests that a 50-minute pause between is enough for kind of the neurons to reset and be ready to learn again. So if we think of back to like neuroscience class, there's sort of like a refractory period where, you don't just boom, 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 bombard the neurons with stimulation. You have to pause. So what happens in practice is the patient gets the session, and then they typically go to a private room or sort of private waiting area, lounge, depending on the practice, and hang out for 50 minutes. They can read, they can go on the internet, they can go out for, go to Google Cafe, whatever they want to do, as long as they're not, doing something inappropriate. They can then get the treatment again. And so it's like a 10-hour day if they do the full day. There's other people out there that, really will do less. It's still considered accelerated if you do 5 a day. Like, we just 10 a day, 5 days. It's like very neat and tidy. That's what the same trial was. That's what we strive for, wherever possible for patients. And our practice is called Fermata, which is I'm not super musical, but my husband is, and Fermata means sort of an intentional pause in music, intentional pause in the composition. So we think of it as you're taking sort of an intentional pause from whatever you're doing in life to do this treatment for a week in order to get better.
Back to life. Speaking of taking a pause and getting back to life, right, Dr. MacMillan? So that's for the accelerated protocol. And is that all you do at your practice now, or do you do a combination of the accelerated and the traditional?
We do a combination of the accelerated and the traditional. We are in network with Medicare. I think our Medicare has a generally favorable policy for TMS, and we like to be able to offer that to folks who certainly can't afford the private pay. And then we also are in network with Cigna, or Evernorth is their behavioral health, because we actually have a very, very good relationship with the behavioral medical director at Cigna. He's a huge proponent of TMS and has been working with us and being more innovative. And so we do traditional Cigna TMS with the hopes that they may be one of the firsts to ultimately pay for the accelerated. They were the first really national payer to cover Cigna, cover OCD, and that was through essentially piloting with our prior practice. We had a large group practice, and we were able to pilot getting OCD covered. And then, a year or so later, they announced a national coverage policy. So, we like to work with payers who want to get good results, and they're actually interested to hear the evidence. And so we're not broadly in network with a ton of payers, because if we can't align the incentives, that doesn't make for a good experience for everyone. But there are payers out there like that are excited about this.
Awesome. And speaking of that, if people are listening and they're like, wow, this is exciting, we should get it covered more, do you have any suggestions or ideas for what the general public can do to help bring this to the forefront and maybe get more payers to be interested in covering a treatment like that, whether the traditional at least or the accelerated?
Yes. So the traditional, in general, people should have that covered. There are a handful of very handful of local policies here and there that may not cover it. And we've heard, like in the state of New York, I will not name them, but there is one managed Medicaid player that does not cover it. So there are some advocacy efforts going on. If you happen to have that that plan, certainly advocating to the plan, saying, "Hey, I want this," could go a long way, because some of it is sort of demand based. If they don't hear their members asking for it, they won't do it. For the more accelerated types of TMS, if you work for a company that has what's called self-funded insurance, which basically usually larger employers, tech employers, big, actually I think even like Broadway's union is self-funded, like companies that basically can pick and choose and design health insurance plans. They don't just take one out of the box. Those HR people at those companies can advocate, and when they go to design their benefit plans, they can work with some novel solutions to try to get this covered. There's a company out there called First Tracks that's doing this in this space, where they work with forward-thinking employer groups to say, yes, you know what, you have your general mental health coverage, but we're going to cover accelerated TMS for your employees. So we've done some of that. We've had some success with some of those forward-thinking employers. That comes from employees at the company saying, hey, I need this. And if you think of, like, if you're running a company, you do not want your employee to be out on medical leave for depression for, months at a time, or if they have a loved one, like, you want them to get better. So you're aligned to getting treatments that work. And this treatment actually, the return on investment for it means less emergency room, less psychiatric hospitals, less residentials, right? So it actually becomes quite cost effective for those type of employee groups. So you can ask that. For Medicare, the Clinical TMS Society has just sent a letter to the appropriate parties regarding this more than one per day rule. We'll see where that goes. If there is going to be a more public advocacy effort around that and a call for people to write in, we'll certainly, if you follow me on social and everything, I will be very loud about that. We're in the early stages, but it will make a difference for if, someone is a Medicare beneficiary to tell Medicare, hey, lift this rule about this one per day thing. This is nonsense. We have over 20 studies. We have an FDA clearance. Like, this is archaic, that you haven't changed this since 2009.
Awesome. So the charge here for the public is speak to your insurers. Speak to your insurers, ask for it, demand for it, be loud about it, and hopefully we can get it.
Be loud about it, and be loud at your HR group as well, right? And they usually, they're picking benefit policies usually in, summer, early fall, or they have to have stuff usually lined up for January 1st. So there's a period of time in which they should be open to feedback, and many of them may not have heard about this. I think, I really have a pet peeve about all of these employee assistant programs and like employers being like, we're going to do something about mental health. Look at our awesome mental health benefit. And it's just like some app that no one's going to use, or like 3 sessions with a therapist, right? And it's not... It's great, it's great for more mild mental illness, right? But if you're truly suffering, it is not going to cut it. And it's not their fault, because we do need more novel companies. So First Tracks is one that's very interested not only in TMS, but ketamine. And ultimately, when the psychedelic medicines like MDMA come online, they're covering that. There's another company that people may have heard of called Enthea. Enthea was in the news for covering the Bronner's soap company employees for ketamine-assisted psychotherapy. So, ketamine is, I don't personally offer ketamine, but ketamine is another one of these, like, rapid acting, like, works a lot better than, a lot of the oral antidepressants. And so companies like Enthea are offering that type of coverage to these employer groups that can be more creative with their benefits, because major commercial payers do not cover ketamine for psychiatric reasons. So these are all kind of ways people can advocate for these novel coverage treatments.
Thank you for sharing that. Now, I'm being mindful of our time, but I have 2 of the questions that I feel like we should touch on real quickly, maybe in under 60 seconds. One is, are there any side effects people should worry about, with TMS, people are considering this? And the other is, say I were doing the traditional protocol, can I go to work after or go about my business, drive after? I think those would be two questions I'd be wondering about as a patient, if you could speak to that.
Yes, both good questions. So the major risk that we worry about with TMS is there's about a 1 in 20,000 chance of a seizure. That goes up a little bit with the deep TMS, but still very low. And that is not the risk of developing a seizure disorder. That is the risk of a seizure during treatment, which, keep in mind, ECT is literally generating seizures during treatment. So, in the rare event that were to happen, the treatment is, immediately stopped. And if the person does need to go to an ER to get checked out, they can. But that is a super rare, time-limited side effect, and we don't allow people to get this treatment if they do have active seizure disorders, that sort of thing. It's not appropriate. The other risks are like mild jaw pain, maybe some mild headache, just because it's focused, but it does have some superficial twitching of the muscles of the face. So that's really the main risk. But one of the things we love about it is it does not have the systemic effects, right? Sexual side effects from SSRIs are a big thing people hate, sort of flattening of mood, all of those things. Some people are really transformed by SSRIs, but for others, the side effects aren't great. So it's really safe from that perspective. As I mentioned, it was safe during pregnancy. So it's really quite well tolerated, particularly for folks who find themselves sensitive to meds. Or I've had people who have like blood clotting disorders or things, and so certain meds they can't have. TMS is no problem. It's basically a problem. Cochlear implants are a problem if you have that, unfortunately, or if you have something in your head that can't go in an MRI. Piercings,
the magnet issue.
Fine. Yeah, okay. Dental work is fine. It's just a rare event that somebody might have some sort of aneurysm clip or something that can't go with an MRI. But these days, most of the stuff that's being put in people's heads are able to go in MRIs. So really good. And then your other question was about sort of the day-to-day. So yes, so you can go to work or school right after. You do not need anybody to accompany you or pick you up. There are no restrictions around driving. You're literally good to go right after. You do not feel, impaired in any way. So that's great. No one will know that you've had it. Now, when people do the all-day one, it's like it's tiring. You're probably not going to want to go out to the club that night, right? But it is, I think, unlike things like ketamine, which again has its place and can be great. That's one where you can't drive afterwards, and you may not feel really right up to just returning straight to work. But people do this on their lunch breaks, especially if they live near. Yeah, they just go right back to work, and no one knows what they did. So
that could be life changing, and being able to get your treatment and not pause in your day to day or your functions in life could be super life changing. All right, that is it. One final question, Dr. MacMillan, where can people find you? I know you've talked about Fermata, so I remember that, but handles, websites, if you want to share that before we go.
Sure. Yeah. So our practice is called FermataHealth, and although we're based in New York, we have licenses in quite a few states, so we're able to do consultations, and then people are able to come in for that week to stay in New York. So we welcome people from really actually all over the world. I'm at Carlene Mac on X, aka Twitter, at Carlene MacMillan MD on Instagram, on LinkedIn, and then my EHR company, which again, I think one of the things about Osmind was why I'm there, as the chief medical officer, is to build tech platforms, build EHRs that are friendly towards all these workflows, because they're workflows. There's measurement-based care. There's different kinds of things we need to document. So that's osmind.org. You can go on there and book a demo. And Osmind has a YouTube channel. I don't really have a YouTube channel, but we do at Osmind and post videos on all this stuff there too.
Awesome. Thank you so very much for your time, sharing your knowledge and wisdom with us. With me, I've learned a lot today as well, with what you've shared about TMS and the new developments. So thank you for your time. That will be all. Again, I'm Dr. Akinronbi, psychiatrist, BrightMindsMD, BrightMinds MD.com. We'll be sharing Dr. Carlene's contact information in this video commentary below as well. Okay, thank you everyone. Thanks for listening and hope you have a wonderful day.
Thank you for listening. Don't forget to share this with a friend or two. Until next time, it's Dr. Bolanle on the Bright Minds MD and Your Mental Health podcast. Ciao.